Hello and welcome to this month's edition of Journal Club. I'm Bethany and I'm one of the clinical managers here at IMV Imaging. This month I've chosen to examine an article on the CT findings in dogs with gastric malposition. If this is your first time joining us for Journal Club, I'll just recap the normal procedure. Our Journal Club presentations are available to view on demand each month and usually last anywhere between 30 and 60 minutes. And you do get a CPD certificate at the end. If you want to get involved, please put any questions in the Q&A box, or alternatively, please email at clinical@imv-imaging.com. As I've said previously, I will be discussing the journal CTE findings in dogs with gastric malposition. It was published in 2020 in the Journal of Small Animal Practice. Gastric malposition has many other names and can be classified under different titles, such as partial gastric torsion, chronic gastric dilation, volvulus, and chronic gastric instability. Finding more information on gastric malposition can present as challenging due to these different conditions falling under these same titles. Presentation within a clinical setting with acute gastric malposition is potentially a life-threatening condition. However, chronic malposition is not in most cases. Typically, these cases would have several diagnostic imaging tools done before heading into CT. This can consist of X-rays, endoscopy, or ultrasound. Chronic gastric instability is defined as a flaccidity of the stomach resulting in intermittent gastric malposition. Dogs with chronic gastric instability can present with a productive history of non-specific clinical signs, including vomiting, lethargy, abdominal discomfort and weight loss. Large breed dogs predisposed to acute gastric dilation and volvulus are also predisposed to chronic gastric instability. Dogs with acute gastric dilation and volvulus present with a sudden onset of life-threatening condition, whereas dogs with chronic gastric instability typically present as an insidious history of less severe and sometimes intermittent clinical signs. It has been postulated that the pathogenesis of acute gastric dilation and volvulus and chronic gastric instability are similar to that in cases of the former in its continuum of the latter. I just wanted to briefly touch on the study aims. So the purpose of this paper, it was written as to describe the CT findings in 6 dogs diagnosed with suspected chronic gastric instability and to identify imaging features between these patients, and also to discuss the clinical significance if the gastric malposition is an incidental or chronic finding, which may prevent unnecessary surgery. This image represents the normal anatomy of a dog's stomach. I would like to draw your attention to the fundus and the pyloric antrum and where they sit in conjunction to each other. Normally, the fundus sits superior to pyloric antrum, and this is something that you need to bear in mind as we go through this presentation. I also just wanted to show you the anatomy of the normal fundus in an 8-seal slice on CT. The anatomy of the fundus in its normal location is indicated by this red arrow. This is a sagittal slice, also showing the normal anatomy of the fundus and its location, indicated by the red arrow. This is an 8-seal slice showing the normal anatomy of the pyloric antrum, indicated by the red arrow. This is a sagittal slice showing the normal anatomy of the pyloric antrum, indicated by the red arrow. This is a coronal reconstruction of the dog's abdomen and pelvis, showing the normal appearance and location of the pyloric antrum, indicated by the red arrow. This image shows abnormal anatomy. The F represents the fundus and the PA is a pyloric antrum. On the bottom is a sagittal slice of a reconstruction. The top right is an 8-seal slice and top left is a coronal plane. I just wanted to quickly discuss the method of this paper. So this paper was retrospective, descriptive case series over 2 separate referral sites over a 3-year period. The inclusion criteria was a complete CT study, CT reports or findings of a displaced pyloric antrum and the fundus, and this decision was made by 2 veterinary radiologists who are board certified. The scans were done over different theories of the scanners with all different slice capabilities. Contrast media was used in every case. The patients were all put under general anaesthetic and they were all positioned in sternal recumbency. All scans were of good diagnostic quality. This table is taken from the journal itself and displays all the patients that were done in this case. We have 2 Great Danes, a Boxer, a flat-coated Retriever, a Newfoundland and a St Bernard. The age range is between 3 and 10 years old, and 5 out of the 6 patients are male and 1 is female. To summarise, Case 1 presented for a workup of hemorrhagic pericardial effusion, chronic vomiting, weight loss and pylorrhea. Case 2 presented with a 24-hour history of vomiting, hemorrhagic diarrhea, lethargy and inappetence. Case 3 presented for a 3-week history of vomiting, retching, hypersalivization and a 5 kg weight loss. Case 4 presented for chronic coughing and lethargy. 2 months prior to this patient had been diagnosed with pulmonary mass in the caudal left lung lobe and a meningioma within the rostral cranial fossa, for which the patient was receiving radiation therapy at the time of presentation. Case 5 presented for a management of a previously diagnosed malignant melanoma in the rostral mandible. Case 6 presented for a skynoscope and hypothermia following cluster seizures. Cases 2, 4 and 5 all had long-term histories of gastroenteropathy and were on specific formulated diets. Abdominal CT was performed 2 months previously in case 5 for investigation of a 3-week history of hemorrhagic diarrhea and vomiting. Alongside the CT with haematology and biochemistry, this was diagnosed as pancreatitis. This case series describes the CT findings of gastric malpositions identified in 6 dogs incidentally or with clinical signs consistent with chronic gastric instability. The abnormally positioned stomach was similar in all 6 cases. The pyloric canal was positioned next to the left cranial abdomen in close proximity to the cardia, and the pyloric antrum was found to the left or ventral to the fundus. The duodenum consistently exited the pylorus on the left of the midline, and the pancreas along with the gastroduodenal vein was also identified left of the midline. Previously published literature describing the radiographic findings of chronic and gastric instability has reported a chronic history of non-specific clinical signs, including weight loss, vomiting and inappetence. All dogs in this study demonstrated a dynamic component in which the position of the stomach changed between the different imaging studies or between the different imaging and exploratory surgeries. 5 of the 6 dogs in this case series presented histories of chronic or intermittent gastrointestinal signs. Cases 1 and 4 had surgery performed within 24 hours of the CT, revealing normal gastric position. Cases 2 and 5 underwent an abdominal ultrasound 48 to 72 hours post-CT that revealed a normal position of the stomach. The spleen was also noted to be correctly shaped and positioned in case 2 during the ultrasound examination, but the spleen in case 5 was not assessed. Prior to the CT studies demonstrating gastric malposition, CT studies had also been performed 2 months previously in case 5 and 1 month previously in case 6. On these previous CTs, the pylori was positioned in the midline and the gastric body, fundus and spleen were correctly positioned. These findings are similar to that as described as Fredrin et al., whereas an upside-down radiographic appearance of the gastric axis was seen in 3 dogs that were later discovered during surgery to have correctly positioned stomachs. Dynamic gastric position has more recently been described in a case series of 7 dogs with chronic gastric instability that underwent radiographic, ultrasound and endoscopy investigations. Similar to what has been described previously, the 6 cases of suspected gastric instability in this study appear to be dynamic, in which the stomach intermittently assumes an abnormal position. This may explain the intermittent and chronic clinical signs. Case 6 had no previous or current signs of gastro disease, and although cases 4 and 5 had histories of intermittent gastroenteritis, similar to previous report of chronic gastric instability, They were not symptomatic at this time of presentation. These cases highlight the important point that gastric malposition may be detected as an incidental finding on CT in patients presenting from non-related conditions. And although gastroscopy may benefit these patients, the identification of gastric malposition does not necessarily warrant immediate surgical intervention. Awareness that a malpositioned stomach on CT may be an incidental finding in some patients may also prevent deflection from the more current issue of the patient. The displacement of the stomach in all 6 cases was similar. When viewed from a caudal to cranial direction, the pyloric antrum rotated approximately 90 to 180 degrees ventral to the fundus in a clockwise direction, with a final position between the fundus and the left abdominal wall. When viewed from a cranial to caudal direction, as in the convention of the transverse plane, this is seen as a 90 to 180 degrees anti-clockwise rotation. The fundus was medially displaced in all cases. During a gastric dilation and volvulus episode, the stomach is rotated 180 to 360 degrees. Therefore, a rotation of 90 to 180 degrees, as seen in the dogs in this study, may represent a partial torsion. Partial gastric torsions were first described in Booth and Ankerman, 1976. The torsion described in the dogs in this paper are similar to those dogs in these case series, with the pylorus position ventral to the cardia in the left abdomen and the rotation approximately 90 to 130 degrees. Previous authors have theorized that gastric instability may be a predisposing factor for genetic dilation and volvulus. Supporting this theory, the 5 breeds in this case were typical of those commonly presented with gastric dilation and volvulus. Both intrinsic and extrinsic factors have proven a role to play in this pathogenesis of gastric dilation and volvulus. Body conformation, notably larger breed dogs and those with large thoracic height to width ratios, is acknowledged as an important predisposing intrinsic factor. Therefore, an association between the conformation in these breeds and the degree of the mobility of the stomach is possible. This instability may manifest as dynamic malposition of the pyloric canal and the pyloric antrum, as seen in this group of dogs, which may lead to a complete torsion as seen in cases of gastric dilation and volvulus. It is unknown if the chronic gastric instability is a separate entity or the predominant stage of gastric dilation and volvulus. An additional finding in these cases was an abnormally positioned spleen. In 4 dogs in this study, the dorsal aspect was found in an abnormal caudoventral position, ventral to the kidney. In the other 2 cases, the dorsal aspect was found in a ventral position, ventral to the fundus, with the ventral aspect forming a cranial bend caudal to the liver. In the normal anatomy, the dorsal aspect of the spleen is closely associated with the greater curvature of the stomach due to the gastrosplenic ligament. This results in the dorsal aspect having a relatively fixed position between the fundus and the cranial pole of the left kidney. As the stomach rotates through the gastric dilation and volvulus, the fundus along with the spleen are displaced to the right. The splenic displacement seen in these cases may result of the malpositioned stomach and a possible feature of chronic gastric instability. Gastrosplenic ligament laxity is another possible cause of the splenic displacement, and there is proposed theory that repeats episode of gastric dilation or partial gastric dilation and volvulus may stretch the gastrosplenic and splenocholic ligaments sufficiently to allow the splenic hypermobility. However, it is unlikely that the patient in this case had splenic torsion at the time of the radiographs that were required, as the CT performed immediately before the radiographs showed only displacement and no torsion. The reverse C-shape in this case is likely the result of a displaced spleen, which is consistent with the CT findings. There are several limitations to the study, including the retrospective study design, which resulted in variable in the level of detail provided in the clinical history and the diagnostic investigation performed for each case. The second limitation is that the small sample size, only having 6 cases, precludes the possibility of performing statistical assessment and therefore the identification of factors that may predispose this condition. Although certain trends have been identified in this series, a larger sample size is necessary to see if these findings could be explored in the general population. So to summarise in a conclusion, the conclusion that gastric malposition was identified in 6 dogs who either had a history of chronic or intermittent gastroenteropathy or as an incidental finding. The CT findings in all cases were similar, with the pylorus identified to the left of the cranial abdomen and the dorsal aspect of the spleen occupying an atypical ventral position. Recognition of gastric malposition as an incidental or chronic pathology finding may prevent unnecessary emergency intervention on patients presented from an unrelated condition. I thoroughly enjoyed looking at this paper and I feel like I've learned lots from it, and I hope you all have too. And that's all from me, so thank you so much for joining me in this month's journal club. If you have any questions, please feel free to drop us an email at clinical@imv-imaging.com. See you for next month. Thanks, bye.